Okay, how many students are there? Let me see. Okay. Good morning, students. Are you there or sleeping? At least one should respond so that I can start. Hello.
Yes, doctor. Hello, we are here.
Okay, good, good. Okay, good morning to everyone. Today we are going to discuss anti-epileptic drugs. Okay, actually this is a huge lecture. In the past, it used to be in 2 lectures, but since already we have so many lectures in neurosciences from pharmacology, so we decided to cut it short to discuss the major drugs. And of course, I will give you the formulary from this lecture also. So the major drugs which are widely used and which have some historical perspective. Okay, so exactly what we are going to discuss today, we will classify various anti-epileptic drugs. We'll discuss the mechanism of action, pharmacokinetics, and significant drug interactions of anti-epileptic drugs. And of course, we will discuss the pharmacological management of status epilepticus, which is slightly a different entity. And finally, I have prepared a table for you where I have mentioned the drug of choice and the alternative drugs in various types of epilepsies. Now, can anyone tell me the difference between epilepsy and seizure? Is there anyone, small boy or girl? These two terms are generally synonymous. I mean, they are used interchangeably, but they are not the same. A seizure is one event or a convulsion in a single occurrence, whereas epilepsy is a neurological condition characterized by two or more unprovoked seizures. So you can say epilepsy is a chronic condition where the seizure is a one activity or convulsion is a one activity, one manifestation of epilepsy or other disorders. But seizure is a manifestation of epilepsy, but not only epilepsy, of various other neurological or other metabolic disorders. So epilepsy is a chronic disease manifested by convulsions, but convulsions may occur in other non-epilepsy conditions like neurological trauma, infections, brain tumors, or stroke. I came across a BBL case yesterday where you found anti-epileptic drugs used in stroke or head injury because of this. Because that was not epilepsy, but anti-epileptic drugs were used to prevent those convulsions. So the bottom line is from these two bullets, the conclusion is many anti-epileptic drugs are also effective in treating or preventing other seizures. Other seizures means non-epileptic seizures. So they should be referred to as anti-convulsant rather than anti-epileptic drugs. Did you get my point here? Generally, the historical term is anti-epileptic drugs, but because of their clinical use, they may not be used in all the situations as anti-epileptic, but anti-convulsant, yes. So they are more commonly referred now as anti-convulsant drugs. Classification of seizures. Can anybody tell me that have you received the lecture from clinical side regarding the epilepsy? Not yet? Hello? Partial seizures. There are two types, simple partial and complex partial. Simple partial, it lasts for half to 1 minute, often secondary, no loss of consciousness, convulsion of a group of muscles or localized sensory disturbance. And then we have complex partial, which is also known as temporal lobe epilepsy or psychomotor, lasts 1 to 2 minutes. Aura often precedes impaired consciousness, purposeless motor movement, confused state. I'm not sure whether I should go into detail of this classification or not. Anyway, briefly. Then we have a second category, generalized seizures, where there are grand mal, generalized clonic, and extended seizures, which are also known as petit mal. And then we have atonic, myoclonic, infantile, and finally the status epilepticus. Okay, let's move to the pathophysiology. What happens during the fit or seizure or convulsion during epilepsy? Various mechanisms have been put forward. Excitation, because it is excessive neuronal activity, excitation too much, and there may be ionic invert sodium or potassium curves, which will cause depolarization and propagation of action potential and increased neuronal excitability, too much excitation because of these invert curves. Or various excitatory neurotransmitters like glutamate and aspartate. There may be more activity or their concentration may be enhanced. So either too much excitation or too little inhibition, because there is inhibitory neural transmission. When that is inhibited, that will lead to balance in favor of more excitation, although absolutely excitation may not be increased. But because of the too little inhibition, the balance will shift towards more excitation, leading to increased neuronal excitability or convulsion. In inhibition, ionic inward chloride or outward potassium currents are decreased, or neurotransmitter GABA is enhanced. So in both the situations, either too much excitation or too little inhibition. Now keep in mind, based on this basic thing, all the drugs which we are going to discuss work through one of the mechanisms. Either they decrease the excitability or they increase the inhibition of the neurotransmission. Any question till now? Hello?
No, it's all clear until now.
Okay, good. So let's move to anti-epileptic drugs. We have two classes, classical, which have been used since decades. We have a lot of experience of using these drugs. Very nice. Most of them is broad spectrum, effective against various types of epilepsies. And phenytoin, carbamazepine, valproate, ethosuximide, benzodiazepines, barbiturates, which have been discussed already by Dana, who delivered the lecture from 8 to 9. Dana or Atuf? Hello?
Al-Hatuf, Dr.
Dr. Atuf, okay. So she must have covered benzodiazepines and barbiturates. I will just briefly touch upon those two. These are the classical drugs which we are using since decades. And there are some newer anti-epileptic drugs: gabapentin, lamotrigine, tiagamine, topiramate, felbamate, zonisamide, pregabalin, and vigabatrin. Just keep in mind that we are not going to cover in detail all those drugs. So I will provide you a student formulary in the last slide. So we will mainly focus on the classical drugs, which are most commonly used. First of all, the classical drug, the first anti-epileptic drug which was used clinically, phenytoin. It is the oldest anti-epileptic drugs, introduced in 1938, before the Second World War. It stabilizes neuronal membrane to depolarization by decreasing influx of sodium ions in the neurons in the resting state or during depolarization. Now you know the role of sodium ions in depolarization. When sodium ions entry is inhibited, there will be decreased excitability in the neurons. At high concentration, phenytoin potentiates the effect of GABA, similar to benzodiazepines and barbiturates. Pharmacokinetics, generally, we do not focus much on pharmacokinetics, but in the case of phenytoin, it is extremely important to know the pharmacokinetics of this drug. The intestinal absorption of phenytoin is erratic, and plasma concentration can vary widely, and this has important implications. If plasma concentration varies, it has a lot of implications. For example, if the concentration achieved in the serum is below a therapeutic range, that means the drug will not be effective, and the patient will not become seizure free, and will experience repeated attacks of convulsions. So, manifestation of epilepsy will not be alleviated. Or conversely, if the absorption is very high because it is erratic, if the absorption is very high, this drug, in the next slide, I am going to show you, this drug has got a low therapeutic index, can easily, at the same dose, can easily become toxic. Kinetics, the first order to zero order. Generally, when we talk about first order or zero orders, do you remember those concepts from BOD? Please respond at least one student so that I can know that you are listening. Do you remember the concepts of first order kinetics and zero order kinetics from POD? None of you? Okay. In the case of phenytoin, first order to zero order from low dose to high dose or therapeutic range. I will show you in the graph C. Now, if you remember, we imparted this concept to you several times. First order kinetics, when the rate of elimination of the drug is proportional to the drug reaching the circulation. If you increase the dose of the drug, accordingly the rate of elimination will also be accelerated. So a constant, we make a definition of first order kinetics as a constant fraction of the drug, not the amount. Constant fraction of the drug is being eliminated from the body at any given time. So that constant fraction depends upon the amount of the drug present in the body. More the amount of the drug in the body, more will be eliminated. Less will be eliminated. So this is the first order kinetics, and keep in mind, majority of the drugs clinically used, they follow first order kinetics of elimination. Conversely, the zero order kinetics is the one where not the constant fraction, but a constant amount of the drug is being eliminated per unit time, irrespective of the dose. If you increase the dose, the rate of elimination will not be accelerated. That will be constant. Why the difference? Because for majority of the drugs, the drug metabolizing enzymes in the body are not saturable. If you increase the dose, more the concentration in the plasma, more of those enzymes will be recruited into the drug, they will be enhanced, and the drug will be metabolized or degraded at a greater pace. So in the case of phenytoin, what happens? Initially, if you look at this curve, this follows a first order kinetics, the plasma concentration on the Y and dose on the x-axis. If you increase the dose, there will be not much fluctuation in the plasma concentration, because by increasing the dose, the drug metabolized will also be increased. However, after certain limit, all of a sudden you will find there's a steep rise in the plasma concentration from here. If you slightly increase the dose, the accumulation of the drug will happen in the body, making this drug extremely toxic. So here, this is a crunch point. Up to here, the drug follows the first order kinetics of elimination. You increase the dose slowly, and then the drug will be eliminated accordingly. A constant fraction of the drug is being eliminated. From here, if you increase the drug metabolizing enzymes have become now saturated. Further increment in the dose is not able to recruit or to enhance, to activate more enzymes, and the drug follows its character from first order kinetics to zero order kinetics, and the plasma concentration will suddenly jump after a slight increase in the dose. So what we can say, this is a unique drug, Then initially it follows first order kinetics. With slight increase in the dose, it changes its characters from first order to zero order kinetics, and the drug will accumulate. So easily it can become toxic. Clear? Therapeutic uses effective in most forms of epilepsy except absence seizures. Prevention and treatment of seizures occurring during or following neurosurgery. Trigeminal neuralgia. Cardiac arrhythmias. Can anybody explain why it can be used in cardiac arrhythmias? Hello. Now, if I give you the first lecture in this block was anesthetics. I don't remember who took it. I think Hatup took it. She must have described the drug, prototype drug lidocaine. Now, if you recall the mechanism of action of lidocaine and the mechanism of action of phenytoin, they are very, very similar sodium channel blockers. So if you use phenytoin in injection form, it can also be local anesthetics. Likewise, lidocaine and phenytoin both are anti-arrhythmic drugs. You will learn more in cardiovascular block next year because sodium channels present in the myocardium are also very, very similar, not the same, but very similar to the sodium channels present in the neuronal tissue. So any excitable tissue which possesses sodium channels, if they are blocked by these drugs, accordingly the pharmacological actions will be produced. If the tissue happens to be neuron, excitability will decrease by both lidocaine and phenytoin. If the excitable tissue happens to be myocardial, excitability over there will also be decreased. So this activity can be useful as an anti-arrhythmic drug. You will learn more in next year. And of course, when used parenterally, intravenously, it can be used in status epilepticus. Adverse effects of phenytoin are too many, and very serious. Mild GI irritation, okay, acceptable. Ataxia and diplopia, that is also acceptable in the sense that it goes away after a few weeks. Blood dyskinesis also not very significant because they go away after some time. Osteomalacia, important. Gingival hyperplasia, I will show you the slide, next slide, and you will see how serious it is. Gum hypertrophy or gum hyperplasia. Hirsutism, and most importantly, during pregnancy, it is absolutely contraindicated. It cannot be used because it is highly teratogenic, and the phenomena occurring in the infants after its use by mother during pregnancy is known as fetal head-and-twine syndrome, which is characterized by mental disorder, cleft lip, low set ears, and nail hyperplasia. Now you can figure out this. This is a true pictures of gum hypertrophy. On the left, it's a milder, it is not milder, moderate. On the right, it is severe gum hypertrophy caused by the phenytoin. Drug interactions are also important since phenytoin induces the metabolism of other drugs. Induces the metabolism by interfering with the cytochrome P450 enzymes in the liver in the phase 1 reactions. Thereby, the simultaneous administration of phenytoin with barbiturates, carbamazepine, alcohol, oral contraceptives, digoxin, doxycycline, the metabolism of these drugs is induced. What does this mean? If the metabolism of these drugs will be induced, that means they will be cleared from the body at a quicker pace. The plasma concentration of these drugs will be achieved less, and these drugs may lose their effectiveness. Those who have to be very, very careful while co-administering phenytoin along with these drugs. So the conclusion is By virtue of inducing the metabolism of these drugs, phenytoin decreases the effectiveness of these drugs. Is that clear? You can figure out the contraindications from the pharmacological actions. Brady arrhythmias, because it decreases the myocardial excitability. You cannot use if the person already has bradycardia, and because it is severe teratogenic, you cannot use this drug during pregnancy and lactation. The other classical drug is carbamazepine, which is even more widely used than phenytoin because it is relatively safer compared to phenytoin. Similar mechanism of action to that of phenytoin, but with fewer adverse effects, much better than phenytoin. Effective like phenytoin, effective in most forms of epilepsy, except absence seizures, and it is particularly effective in psychomotor epilepsy, complex partial. Also useful in trigeminal neuralgia and mania. Pharmacokinetics absorption is slow and erratic. Plasma half-life is 10 to 30 hours. A strong inducing agent, therefore, many drug interactions like phenytoin. Rather, compared to phenytoin, carbamazepine is notorious for causing so many drug interactions. Adverse effects are fewer than phenytoin. Sedation, ataxia, mental disturbances, but low compared to phenytoin. Driving is dangerous because of the sedation. Driving is dangerous for patients taking carbamazepine or operating heavy machinery, which can be dangerous. It is a teratogen like phenytoin, but to a lesser degree. This risk of teratogenicity can be minimized or decreased by simultaneous administration of high dose of vitamin B6 by the pregnant mother. There are several studies which have shown the co-administration if the patient is suffering from epilepsy and he is already well controlled on carbamazepine and the woman plans a pregnancy. Before planning the pregnancy, you start vitamin B6 in a high dose, and in most of the situations, the pregnancy is safe. There's no any teratogenicity if you give vitamin B.
Excuse me, doctor. You said vitamin B6 twice, and it's written vitamin B12. So which one?
Oh, it is vitamin B12. I'm sorry. It is vitamin B12, not cyanocobalamin.
Oh, okay, thank you.
Cyanocobalamin. Okay. The third classic drug is valproic acid, also known as the salt of valproic acid, is also known as sodium valproate. Broad spectrum, anti-convulsant. And since you will see, it has got multiple mechanism of actions. Because of the multiple mechanism of action, it is broad spectrum. Effective against various forms of epilepsies. The drug inhibits GABA transaminase enzyme, and this is the enzyme which is responsible for the degradation of GABA. Now, in the POD, I delivered the lecture on introduction to ANAs. The same happens in central neurotransmitters. Action potential arrives, preformed neurotransmitter is released, it acts on the receptors postsynaptically, and then there's the fate of the neurotransmitter. Either it is degraded in the synaptic cleft, or it is recycled back into the presynaptic neuron. This happens. This is true for all the neurotransmitters, common phenomena. Now, in case of GABA, in CNS, the fate of GABA, one important mechanism for the termination of effect of gamma is the degradation of this neurotransmitter by gamma transaminase enzyme. So valproic acid, sodium valproate, it causes inhibition of this enzyme. Therefore, degradation of the GABA does not happen or is inhibited. That leads to increased concentration of GABA in the brain. And when there is increased concentration of GABA in the brain, remember the initial slide, pathophysiology mechanisms, you are actually increasing the inhibition. That means you are decreasing the excitability of the neurons. that will be translated into its anti-conversion effect. One mechanism. Second mechanism, similar to that of phenytoin, it also blocks sodium channels. The third, and also very, very important because only few drugs are there which have this mechanism of action. They reduce T-type calcium current, inhibits abnormal firing originated from thalamus. If somebody has told you the pathophysiology of various types of epilepsy, this in the thalamus, there's a predominance of T-type calcium channels, and they have been implicated in some particular types of seizures. When those are inhibited in thalamus, a particular epilepsy can be elevated only and only by those drugs which inhibit the T-type calcium current in the thalamus. So this is the mechanism of action of sodium valproate. Indications: it is very effective in absence seizures, partial seizures, generalized tonic-clonic seizure, and it is also mood stabilizer. And some psychiatrists will tell you it is very good in mania and bipolar disorders. Adverse effects are many: GI symptoms, tremors, sedation, ataxia, rashes, and alopecia. And sometimes, in rare cases, fulminant hepatic failure can occur, which can become fatal. And it is also highly teratogenic. It is absolutely contraindicated during pregnancy. It may cause spina bifida. Another classical drug, ethosuximide. Now remember, I mentioned in sodium valproate about the calcium channels in the thalamus. A brief introduction. In the brain, there are three types of calcium channels, L, N, and T. The influx of calcium currents in the resting state produces a partial depolarization of the membrane, facilitating the development of an action potential after a rapid depolarization of the cell. T-type calcium channels in the thalamus play a role in the spike and wave discharge of the absence seizures. Now keep in mind, why I didn't say about phenytoin, carbamazepine, they are broader spectrum anti-epileptic. They are used against a variety of epilepsy. But specifically, I mentioned, if you remember, these are not effective in absence seizure. Do you remember? In phenytoin and carbamazepine. And in valproate, I mentioned, if we go back, effective against absence seizure. Because of this specific activity I mentioned, is the inhibition of calcium, T-type calcium current in the thalamus, which are the focus of absence seizures. So T-type calcium channels in the thalamus play a role in the spike and wave discharge of absence seizures. So any drug which inhibits these currents in the thalamus will be effective in absence seizures. Drugs that inhibit these T-types I mentioned. Ethosuximide acts by blocking T-type calcium channels, and it is the main drug used to treat absence seizures. Relatively few unwanted effects, mainly nausea and anorexia, mental disturbances, and hypersensitivity reactions. Benzodiazepines were covered already in the morning, briefly. They are not used routinely. They are only used, I will show you in the later slide, only in the status epilepticus. They are mainly sedative, hypnotic, anxiolytic drugs, bind to GABA receptor complex, causing increased affinity between GABA and its receptor. Keep in mind, at the end of the semester, when we ask questions in the examination, students generally, although we try to clarify this concept, but somehow they have this misconcept that benzodiazepines and barbiturates, they are GABA receptor agonists. Keep in mind, they are never GABA receptor agonists. They bind at a site which is distinctly different from the GABA receptor. So GABA receptor, we don't say GABA receptor, it is a huge receptor we call it GABA receptor complex. So that big protein, which we call GABA receptor complex, that provides binding site for so many ligands. One of them is benzodiazepine, one of them is barbiturates, and there are others, cannabinoids, corticosteroids. The same receptor complex provides binding sites, and it also provides binding sites to GABA receptor. So benzodiazepine binds to a site which is distinctly different from the GABA receptor. Keep in mind. So benzodiazepines are never GABA receptor agonists. But having said that, binding of benzodiazepines with their own receptor makes a conformational change in the receptor so that in the presence of benzodiazepines, the affinity between GABA and its receptor is enhanced. So GABA becomes more effective in the presence of benzodiazepines. And you know GABA is inhibitory in nature. So this leads to increased frequency of opening of chloride channels because chloride channel is coupled with GABA receptor. Increased frequency. So diazepine preferred drug for status epilepticus because it is sedative, hypnotic. You can't use routinely for patients with epilepsy because they will be always sleeping. The patient may require treatment for life or 5 years, 10 years. You can't use this drug for so many years. So it is only used for status epilepticus. Similar drug, barbiturates, and the classical prototype among them is phenobarbital. Now, similar to benzodiazepines, but a different, distinctly different site. Different site for GABA, different site for benzodiazepines, and different site for barbiturates. Binds to GABA receptor complex, causing increased affinity between GABA and its receptor, similar to benzodiazepines. Now, the difference is this leads to increased duration of opening of chloride channels. In the case of benzodiazepines, it was increased frequency of chloride channel opening. Here it is increased duration of opening of chloride channels. Eventually, the outcome will be very, very similar. Decreased neuronal excitability because of this GABA activity, but the molecular mechanisms are different. Another difference between benzodiazepines and barbiturates is that at higher dose, not benzodiazepines, but barbiturates directly activate GABA receptors. Now, at higher doses, they can directly activate a GABA receptor, they become GABA mimetic. And this is the difference why barbiturates can become fatal, whereas benzodiazepines cannot become fatal. They are very safe, barbiturates are not safe. Similar to phenytoin, it is inducer of microsomal enzymes, so there are various drug interactions with barbiturates. Toxic effects, somebody mentioned in the morning, Hatu. Okay, this was mentioned. Okay, used in the treatment of generalized tonic-clonic seizures, and mainly it's used like benzodiazepines is in status epilepticus. Now, newer, briefly, gabapentin, more than the epilepsy, nowadays it is used for pain, chronic neuropathic pain. It is analog of GABA, but does not act at GABA receptors. Mechanism of action unknown. Indicated in partial seizures, post-herpetic neuralgia, and it is widely used in chronic neuropathic pain. More than the epilepsy, now this is the clinical use. Lamotrigine, this is a broad spectrum, now it is widely used. Blocks sodium as well as voltage-dependent calcium channels. Effective in partial seizures, generalized seizures, absence seizures, bipolar disorders, it is very broad spectrum. Tiagabine interferes with GABA reuptake, you can figure out when a drug which interferes with the reuptake of a neurotransmitter, as I mentioned already 10 minutes ago, the fate of neurotransmitter, the action of neurotransmitter is terminated by two ways. Either it's degradation in the synaptic cleft or recycling of the same neurotransmitter back into the presynaptic neuron. So this drug, diagabine, inhibits the reuptake of GABA. That means when the GABA recycling is inhibited, GABA will remain in the synaptic cleft for prolonged periods of time. That means sustained inhibition can be obtained. When GABA is there at the receptor site for prolonged periods of time. Another neurodrug, topiramate, blocks sodium channels at high firing frequencies and also increases frequencies at which GABA opens chloride channels, similar to benzodiazepines once again, but the binding site is different from benzodiazepines. So we won't call it benzodiazepines, the binding site is different, but the mechanism of action, the ultimate outcome will be similar to benzodiazepines. Sodium channel blockers and increased opening of GABA or chloride channels. Felbamate blocks sodium channels at high firing frequencies. In addition, it blocks glutamate receptors, which you know is excitatory. By blocking the excitatory neurotransmission, you are actually getting the neurotransmission in favor of more inhibition, decreased excitability. And it also potentiates GABA evoked responses. I think this is the last drug. Zonisamide blocks sodium channels and T-type calcium. Only few drugs are the ones which block T-type calcium channels, and most widely used in Epilepsy and Seizure is ethosuximide. The second most is sodium valproate, and this newer drug, zonisamide, is the one which blocks T-type calcium channels in thalamus. Also enhances GABA transmission. Pregabalin increases neuronal GABA, decreases in neuronal calcium currents by binding with voltage-gated calcium channels. Please don't be confused with so many drugs. I'm not going to assess you on these drugs. Finally, the last learning object is drugs for status epilepticus. Status epilepticus is a condition when there's a severe tonic-clonic seizure happen in quick succession, so that the recovery phase is not obvious. It feels that the convulsion is continuous. That is why we call it status epilepticus. So it is so serious. It has to be, this attack has to be terminated immediately, and you can't rely on oral drugs. You have to administer parenteral drugs to terminate this acute attack of status epilepticus. And lorazepam is benzodiazepines. It is used intravenously, and it is highly effective. Within a minute or so, it terminates the attack. Diazepam, another benzodiazepine, intravenously. Phenytoin, intravenously. Phenobarbital, once again, I haven't mentioned, I have forgotten, intravenously. And if all these drugs, barbiturates, benzodiazepines, or phenytoin are not successful in terminating the acute attack, the last resort is anesthesia, general anesthesia. It is used with midazolam and propofol. Somebody must have mentioned in the first lecture on anesthesia, these drugs. Now this table I created for you. Okay. Type of epilepsy, the common types of epilepsy, I have mentioned the first choice and then the second choices. If these are not successful or there is some contraindication for their use or when they are not effective. For generalized, phenytoin and carbamazepine, if because of the pregnancy or other issue, these drugs are not successful or contraindicated, you can go to primidone, and this one I underlined it, the newer drug lamotrigine is very important. In Epilepsy and Seizure, ethosuximide is the drug of choice, best. because it has got fewer side effects and it is very, very specific for inhibiting T-type calcium currents in thalamus. In the failure of ethosuximide, you can go for valproic acid and lamotrigine. These are the drugs. And accordingly, I have mentioned first choice and second choice. However, for your ease, many of the students are asking, there are so many drugs. I have prepared a formulary from this lecture for you. Few drugs which are very, very important, and all the focus in the SAQs, in the MCQs will be from these drugs. Phenytoin, carbamazepine, these classical drugs are very, very important, and they are widely used. And apart from these classical drugs, gabapentin is also widely used, newer anti-epileptic drugs, and lamotrigine. So just 3 and 6 drugs. 3, 4, 5, 6, 7, sorry. Pregabalin is also there. I don't know what is happening. Anyway, so 7 drugs are in the formulary from this lecture. If you have any question, please ask me.
Yes, doctor. Can you go back to the gabapentin slide?
Sure. Yes.
Yes. Can you please explain what is post? Sorry, I read it wrong. It's clear now.
Post-herpetic neuralgia.
Yes.
Post-herpetic neuralgia is a chronic pain associated with it, especially in the elderly. Have you heard about herpes zoster or shingles?
Yes, POD.
Did you hear about it in the POD, herpes zoster infection? So that is basically the infection of the single dermatome by the herpes zoster virus. The acute phase is just like chickenpox. There are some blisters and there is itching and some pain that goes away spontaneously within 1 or 2 weeks. However, because the nerve is involved and that infection persists several years, it may come back not as an infection, but the inflammation of the nerve known as post-herpetic neuralgia, the pain in the nerve as a result of past infection of the dermatome resulting in the neuralgia because of the herpes zoster infection. Are you familiar with herpes zoster or not? Tell me first.
Yes, we are.
Okay, so in that case, herpes zoster, the acute attack is just blisters and itching. But in some patients, especially in the elderly patients, several years later, after the acute infection, it may come back. Now, at this time, the manifestation would be severe pain in the same area where the past infection was manifested. So this condition is known as post-herpetic neuralgia. So gabapentin is very, very useful in that type of pain. Not only that type of pain, but in almost all the chronic pains, undefined neuropathic pains, patient may complain of chronic pains. This drug is very, very effective.
Thank you.
Anything else?
Doctor, can you go over the role of GABA in chloride conductance again?
Role of what?
GABA in chloride conductance.
Okay. Now, there is no slide, but because I was assuming that it was well covered in the lecture in the morning. Okay, let me clarify. Now, several receptors are coupled with ion channels, whereas various are coupled with adenylyl cyclase, IP3. Some receptors are coupled with G-protein coupled receptors with ion channels. Now, GABA receptor is a classical one, which is coupled with a chelated channel. Now, when you activate GABA receptor, when the GABA receptor is activated by GABA, what is the next step? What happens after activation of GABA receptor? Tell me. There is opening of chelated channel because that GABA receptor is coupled, there is conformational change, and GABA receptor activation causes opening of chloride channel. When there is opening of chloride channel, what will be the result? Based on the electrochemical properties gradient of the chloride, what do you expect? What will be the movement of chloride from outside to inside or inside to outside? Figure out. If you look at the concentration gradient only, where is the concentration more? Extracellularly or intracellularly? Chloride concentration is more on the outside of the cell or the inside of the cell? Outside, isn't it? So if you open the chloride channel, there will be movement of chloride from outside to inside. Are you clear up to this point? Hello? Hello? Who asked the question?
One of the students. I think it's
Okay.
clear.
Listen, so when the chloride channel is open, there is a movement of chloride from outside to inside. When there is an increased movement of chloride to the inside, that will aid to negativity inside. Because already the cell is negative, it's resting membrane potential, minus 60 to minus 90 millivolt. When there is more negatively charged ions inside, in case of chloride here, there will be more negativity. So there will be, the cell will become now more hyperpolarized. It is already polarized, now it will become more hyperpolarized. In that case, it will go away from the firing threshold. It will go away from the excitability. So basically, chloride channel opening will lead to hyperpolarization. There is decreased excitability. Anything which potentiates the GABAergic neurotransmission will cause hyperpolarization and decreased neuronal excitability. I think it should be clear by now.
It should be. Thank you, doctor.
Okay, welcome. Any other question?
No, that's it.
So, okay, thank you very much. So with this, I am going to upload this lecture on the Moodle right now. And good luck. See you soon. Bye-bye. I
All
believe
right.
in
Thank
the
you,
meeting.
doctor.
Thank you.